Assalamualaikum and a very good morning. So today I would like to present my given orthodontic case presentation for part A. So this is patient's detail. So patient's initials is NAR and date of birth of this patient is 22nd March 1994. So she came with a complaint of overlapping teeth and patient have no any relevant medical history. So these are the extraoral photos. This is the skeletal assessment. For the anteroposterior assessment, patient have class 1 skeletal pattern and straight facial profile. For the vertical assessment, the patient has low Frankfurt mandibular plane angle. As you can see on your left, for the first picture, the intersection between the Frankfurt plane and mandibular plane is posterior to the occiput. And then patient has slightly higher lower anterior facial height. As you can see on the second picture, there's two lines there, green and also blue. The blue line is slightly longer than the green line. For the skeletal assessment, patient has grossly facial symmetrical and competently act. So these are the intraoral photos of this patient. We start with the intraoral examination. The oral hygiene looks fair. The oral mucosa generally looks normal, and the gingiva appears red with sharp interdental papilla. Due to the limitation of this case, because I didn't have the study model of this patient, so I just looking at the clinical picture and also the OPG. So these are the erupted teeth of this patient on the first quadrant, from tooth 17 to 11, and then for the second quadrant, tooth 21 to 2 partially erupted to 3, retain deciduous tooth 6-3, and then 2-4, 2-5, 2-6, and 2-7. For the lower arch, this present from 3-7 to 4-7, and then all 8 missing. So this is for the lower arch. For the lower arch, the shape is U shape. For the labial segment, patient presented with mild crowding with 3-1 rotate mesiolingually, and 4-1 dispace labially overlap with 3-1 and 4-2, and then 4-3 rotate mesiolabially. For the buccal segment, right and left buccal segment are generally well aligned. This is for the upper arch. The shape is square. The labial segment, patient have severe crowding with tooth 1-2 and 2-2 dispace palatally. Tooth 1-3 and 2-3 dispace labially. 6-3 rotate mesiolabially, and I also can notice a spacing between tooth 1-2 and 4-4, and spacing between 2-2 and 6-3. Same like the lower arch, the buccal segment, the right and left buccal segment are generally well aligned. So these are the labial segment relationship. For the inter-arch assessment, patient have class 1 incisor relationship. Oval jet cannot be measured in this case because no study model. Patient also presented with reduced oval bite of 10%, anterior open bite between 1-3 to 4-3 and 4-4, and then lower midline shift to the right, and also anterior cross bite at tooth 1-2 to 4-2 and 4-3, and then for the left side, tooth 2-2 to 3-2 and 3-3. So this is the buccal segment relationship. On the right side, the canine classification is class 2 half unit, and molar classification is class 1. And then for the left side, the canine classification cannot be classified due to the tooth 2-3 is not fully erupted yet. And then for the molar classification is class 3 half unit. Patient also presented with unilateral buccal crossbite on the right side, which involves the 1-4, 1-5, 1-6, 4-4, 4-5, and 4-6. Moving to the radiographical assessment, we start with the OPG first. This is OPG taken in August 2008. The OPG shows all permanent teeth are present except for all axes and presence of retained deciduous tooth 6-3 with only remaining crown seam. Tooth 2-3 is vertically impacted, lies between tooth 2-2 and 2-4. Radiolucency at distal surface of tooth 2-3 near the cemental enamel junction may indicate root resorption, and also radiolucency also noted on the mesial of tooth 2-6 at the cemental enamel junction may indicate. So this is the lateral cephalometric analysis. I traced the lateral cephalometry using webcaf.com. Then these are the findings. First, for the SNA value, the finding is 81 degree, which is maxilla has normal relation to the cranial base. And then SNB value is 80 degree, which mandible has normal relation to the cranial base. The A and B value is within 2 to 4 degree, which is the finding is 4 degree, indicates class 1 skeletal pattern. And then SN and XP is 4 degree, which the value is out of 5 to 11 degree, which Eastman correction cannot be applied. And then MMPA is 34 degree, which means that the inclination of the maxilla relative to the mandible is high. And then UIMXP is 109 degree, which is the inclination of the upper incisor is normal to the maxillary plane. And then LIMNP is 94 degree, which the inclination of lower incisor is normal to the mandibular plane. And then the interincisal angle is 1 to 3 degree, which is the within normal range of the population. And lower anterior facial height is slightly higher compared to the total facial height, which is 58%. So for the classification of dental component for the IOTN for this patient is 40, which is partially erupted teeth, and impacted against adjacent teeth, and it requires orthodontic treatment to upright level and eliminate the problem. Okay, come to the summary of this patient. So this is 26-year-old Malay lady, come with cheek complete of overlapping teeth. She presented with class 1 incisor relationship on class 1 skeletal pattern with low FMPA. They are mild spacing at upper labial segment and presented with moderate crowding at upper labial segment and mild crowding at lower labial segment. There is a retained deciduous canine in tooth 6-3. In occlusion, she has reduced overbite of 10%. There is anterior crossbite presented at tooth 1-2, 2-2, 3-3, 3-2, 4-2, and 4-3. She also presented with anterior open bite between 1-3 to 4-3 and 4-4. Lower midline shift to the right. Canine relationship at the right side is class 2 half unit, and molar relationship left side is class 2 half unit. She also presented with buccal crossbite on the right side at 1-4, 1-5, 1-6, 4-4, 4-5, and 4-6. So these are the problem list of this patient. Patient presented with heavily stain of all permanent sixes on occlusal surface, especially at distal fissures. Patient presented with retained 6-3, mild spacing at upper labial segment, mild crowding at lower labial segment, severe crowding at upper labial segment, reduced overbite of 10%, anterior open bite, anterior cross bite, lower midline shift to the right, class 2 half unit canine classification on the right side, class 3 half unit molar classification on the left side, and buccal crossbite on the right side involving all posterior teeth. So these are the aim of treatments. First, to refer the patient to restorative department for further management of all sixes, to extract tooth 6-3, to eliminate spacing at upper labial segment, to relieve crowding at upper and lower labial segment, to correct 10% overbite, to correct anterior open bite, to correct lower midline shift, to correct anterior crossbite, to correct right canine classification to class 1, to correct left molar classification to class 1, and to correct buccal crossbite on the right side. So the etiology of this case, I come up with two etiology for this case, which is the first one is discrepancy of dental alveolar, as can be seen in the upper and lower labial segment where crowding can be seen. It might be due to large size of teeth and small size of the jaw. So also for the discrepancy of dental alveolar, unilateral posterior crossbite may be caused by the discrepancy between maxilla and mandible in transverse dimension. For the second etiology, retention of deciduous tooth, which is tooth 6-3, causing eruption of tooth 2-3 out of the arch and tipping to tooth 2-2. So these are the treatment plans. For the general treatment plans is oral health education and oral health instruction, scaling and polishing, and also refer patient to restorative department. For the orthodontic plan, I plan to extract the tooth 6-3 and give this patient fixed appliances. And then for the retention phase is wholly retained. Thank you.